everyone and welcome back. So we are going to discuss the topic benign diseases of the uterus and malignant diseases of the uterus in this part of the video. So starting from the benign diseases of the uterus, we are having a scenario of fibroids that 40 years old para 4 presents with polymenorrhagia and 16 week size mass arising from the pelvis. She also complains of weakness and her HB is 7 gram per dl. Another scenario is that there is 18 weeks abdominal mass and menorrhagia and 25-year-old primary infertility. Multiple fibroids are present on ultrasound. So, what are the complications and the future pregnancies in this case? And the scenario 30-year-old P2, severe pelvic pain, dysmenorrhea, and secondary infertility. Another scenario is that there is 18-year-old 6 cm solid tumor with long pedicle, and scenario is that P540 a lady suffering from heavy periods since 1 year. Okay, these are the types of questions that are asked about the fibroid, and fibroid is a benign disease of the uterus. So what is fibroid uterus? It is a benign tumor arising from the smooth muscles of the uterus. It predominantly occurs in body of uterus and less commonly in cervix. Does not occur before menarche and it reduces in size after menopause. Now, the causes of fibroid uterus are estrogen and progesterone dependent tumors, which are higher in fibroids than myometrium. Then it occur after menarche and reduce after menopause, and the size reduce when treated with gonadotrophic releasing hormone analogs. Enlarge in response to OCPs. If already fibroids increase, then if no fibroids, then it decrease in size. OCPs can reduce the risk of the fibroids if it has not occurred already. If the fibroids are present already, then the OCPs aids to increase the fibroid size. Now, the incidence is higher in obese women and it is less in smokers due to low serum estrogen levels. Now, fibroids within the body of the uterus, we have classification which are subserous fibroids, submucous fibroids, and intramural fibroids. The fibroids are within the body of the uterus, then the cervical fibroids, and then the intraligamentary fibroids. The body of the uterus are further divided into intramural, subserous fibroids, and submucous fibroids. Now, the clinical features of symptoms of the fibroids, we have menstrual problem which are menorrhagia and other menstrual problems, then abdominopelvic mass, then subfertility, pain, urinary symptoms, pressure symptoms, and asymptomatic. The investigation options are GP, that is anemia due to excessive loss of the blood. It is pallor and breathlessness is present, edema and varicosities of the leg is present. On abdominal examination, 12 weeks increase abdomen and fibroids form and non-tender. The pelvic examination shows intermittent and postcoital bleeding, intermenstrual and postcoital bleeding. Now, the differential diagnosis of the fibroids are fibroid uterus, H mole, ectopic pregnancy, chocolate cyst, ovaries, dermide cyst, appendicular masses, full bladder, inevitable abortion, ovarian tumors, endometriosis, and intestinal mass. The investigation options are routine investigations, ultrasound investigations of choice, then investigation under special circumstances urgent, which are hysteroscopy and curettage and laparoscopy. Then hysterosalpingography is done and modern imaging technique is done, which is CT scan and MRI, and complete blood picture is taken. The treatment options are the treatment of fibroid is chiefly surgical, though in some cases a medical and even conservative treatment may be offered. The surgical treatment are of two types, that is radical hysterectomy and conservative, that is myomectomy. The radical hysterectomy is a treatment of choice under the following circumstances, that is when the patient age is greater than 40 years of age, when it is present in the multiple fibroids, and when patient who has complete family and has severe symptoms. Now, the conservative surgery, that is myomectomy, is done when it is an operation where the uterus is conserved and fibroid is removed. It is preferred for following conditions, that is symptomatic fibroid within a young patient and infantile patient where fibroid is the only cause, and the patient who wants to conserve her uterus. Now, the management and treatment options are medical treatment, which is mostly for symptomatic relief. Okay, we have discussed this. The infantile patient where fibroid is only cause, patient wishing to have more children, and patient wishing to conserve her uterus. These are the conservative surgery indications. Then the management options are medical treatment is mostly for symptomatic relief. For menorrhagia and dysmenorrhea, we will give the NSAIDs, the transaminic acid, the OCPs, with the gonadotrophic releasing hormone analogs, and we will correct the anemia. The complications of fibroid are torsion, ischemic necrosis of the fibroid leading to acute pain. Sessile fibroid may get adherent to bowel or omentum and develop alternative blood supply, forming parasite fibroid. Then ulceration and infertility and urinary retention or obstruction are the complications of fibroid. Degeneration, that is highly fatty and red cell degeneration, calcification of the fibroid, hemorrhage, anemia, polycythemia and hypoglycemia. Now the next pregnancy depends on the route of myomectomy, that is after abdominal myomectomy in the next pregnancy we will deliver by C-section, but if we do vaginal myomectomy then we can deliver by NVD, and in case of laparoscopic and hysteroscopic myomectomy we can perform NVD. Okay, so we have discussed the benign diseases of the uterus, and we are having the fibroids. We are having the scenario that there is a 40-year-old para present with polymenorrhea and 16-week size mass arising from the pelvis. She also complains of weakness and her HB is 7 gram. That is decreased HB and excessive bleeding, and the uterus is 16 weeks size and she is not pregnant. So what is the diagnosis and what are the investigations, the differential diagnosis and the management? So we have discussed that what is the fibroid uterus, and we have discussed the causes of the fibroid uterus. Then we have discussed the classification of fibroids which is within the body of the uterus, cervical fibroids and intraligamentary fibroids. Then we have discussed the clinical features or symptoms for the fibroids. Then the investigations options which are GPE, abdominal examination and pelvic examination. Then we have discussed the differential diagnosis and the investigations which are routine investigations, ultrasound investigation of choice, investigations under special circumstances, hysterosalpingogram and modern imaging technique, and complete blood picture. Then we have the treatment options which are the surgical treatment. In surgical we will do the radical hysterectomy and conservative myomectomy. These are the conditions for the radical hysterectomy and these are the indications for the conservative surgery. Then what are the management for medical treatment for the fibroids? So for menorrhagia and dysmenorrhea we will use NSAIDs, tranexamic acid, OCPs, gonadotrophic releasing hormone analogs, and we will correct the anemia. The complications of fibroids are torsion, ischemic necrosis of fibroid leading to acute pain, sessile fibroid may get adherent, ulceration, infertility and urinary retention. Then what will we do in the next pregnancy? It depends upon the route of the myomectomy. So after abdominal myomectomy in the next pregnancy we will deliver by C-section, but if we do vaginal myomectomy then we can deliver by NVD, and in case of laparoscopic and hysteroscopic myomectomy we can perform NVD. Now coming towards the next topic, that is malignant diseases of the uterus. Okay, so this is the carcinoma of endometrium. Fibroid is benign disease and the malignant diseases are the cancers. So we are having the carcinoma of endometrium. We are having a scenario that write down the risk factors of endometrial carcinoma and FIGO staging of the endometrial carcinoma. Another scenario is that there is a 54-year-old nulliparous obese woman with family history of diabetes who complains of postmenopausal bleeding, and ultrasound show abdominal thickening of the so what are the differential diagnoses of postmenstrual bleeding and the causes, the risk and investigations and management? The most common female pelvic malignancy, these are the causes or risk factors, that is average age is 61 years and it occurs in the postmenopausal age, the parity that is common in the nulliparous woman, and the late menopause which is common, the obesity that is fits are the sources of estrogen production, diabetes mellitus are common causes, ovarian diseases, hormonal replacement therapy, radiotherapy, family history and tamoxifen therapy. These are the most commonest female pelvic malignancy causes. Now the investigation options are endometrial sampling, that is histological examination of the endometrium is investigation of choice for diagnosis of the carcinoma of endometrium, and fractional curettage is done for the endometrial sampling. Then for vaginal or cervical cytology is taken cytological examinations of the pap smear, numerous cystocytes in postmenopausal smear. Then progesterone challenge test is done, which is the endometrial cancer is estrogen dependent. Pelvic ultrasonography is done, hysteroscope guided biopsy is done, pap smear for carcinoma of the cervix screening is done, and diagnostic D&C is done. Tumor markers are checked, that is for carcinoma 125. These are the investigations. Tumor markers, carcinoma 125. Then the radiological investigations are done, which is X-ray for metastatic disease, and the clinical features are abnormal vaginal bleeding, vaginal discharge, abnormal smear and pen. Now the vaginal or cervical cytology is taken, that is cytological examination of the pap smear, numerous cystocytes in postmenopausal smear, and progesterone challenge test is done, which is endometrial cancer is estrogen dependent. I think I have repeated this. Okay, we have discussed already. Moving towards next page. Now coming towards the staging, the FIGO staging. This page is repeated. Okay. This is the FIGO staging. We are having different stages. That is 1A, which is in which tumor is confined to endometrium. 1B involved the half endometrium, and IC involved the half myometrium. Now 2A is cervical glandular environment, 2B is cervical stromal environment, 3A is tumor invades serosa or adnexa, 3B vaginal metastasis, and 3C metastasis to pelvic and para-aortic lymph nodes. 4A invades bladder or mucosa, and 4B distant metastasis including extra-abdominal or inguinal lymph nodes. Now the treatment of endometrial carcinoma is surgery and radiotherapy, and it is given alone or in combination. Now the stages are total abdominal hysterectomy with bilateral salpingo-oophorectomy is done in stage 1, and adnexa are removed because of risks that they may contain subclinical metastatic tumor. Peritoneal cytology and peritoneal wash should be taken from the pelvis, that is 100 ml of sterile saline with help of sterile syringe, and send it for cytology. Look at omentum and take omental biopsy. Then palpate liver for superficial metastasis. In nutshell, through laparotomy should be performed with particular attention being to the liver and omentum, then adnexa and retroperitoneal node bearing areas. After GAH, cut section of the uterus should be examined to assess the depth of the myometrial invasion. Okay, lymphadenopathy is controversial. If it's performed, it can only tell about the prognosis and involvement of the lymph nodes, which is bad prognosis, and no in lymph node involved, it is good prognosis, and it has no therapeutic effect. Radiotherapy is done. It is done when surgery is contraindicated, and radiotherapy alone is rarely recommended for the stage 1 patient. It also done after the total abdominal hysterectomy with bilateral salpingo-oophorectomy. TAHBSO stand for total abdominal hysterectomy with bilateral salpingo-oophorectomy. Now these are the classification of stage 2, stage 3 and stage 4. Stage 2 is treatment depends whether the spread to the cervix is microscopic or macroscopic. Microscopically involved in this procedure is done to do post-op radiation therapy if moderately or poorly differentiated. If it is macroscopically involved, then cervix radical hysterectomy plus bilateral pelvic lymphadenectomy is done and para-aortic node sampling is done. At stage 2, obtain CT scan of pelvis and upper abdomen. If it is confined to pelvic, then radiotherapy is done, and if clinical spread to adnexa, then laparotomy is done. At stage 4, palliative treatment is done for symptoms control and fever. For fever, antipyretics are given. For anemia, blood transfusions are done, and for infections, antibiotics are given, and for incontinence, surgery or catheterization is done. Now follow-up is done. This is detecting the recurrence and complications of the therapy, then tumor-related problems, which are hormone replacement therapy and breast cancer, and the prognosis. Okay, so we have discussed the benign disease or malignant diseases of the tumor and benign diseases of the tumor. We will revise the malignant diseases of the tumor, that is the carcinoma of endometrium. So we have discussed the scenario that what are the risk factors of the endometrial carcinoma and what is the FIGO staging of the endometrial carcinoma. So the most common female pelvic malignancy is the carcinoma of endometrium, and the causes or risk factors are age, parity and late menopause, obesity, diabetes mellitus, ovarian disease, hormone replacement therapy, radiotherapy, family history and tamoxifen therapy. The investigation options are endometrial sampling and vaginal or cervical cytology, progesterone challenge test and pelvic ultrasonography, hysteroscope guided biopsy and pap smear for carcinoma of the cervix, diagnostic D&C tumor markers, that is carcinoma 125, and radiological investigations are done. The clinical features are abnormal vaginal bleeding, vaginal discharge, abnormal smear and pain. Okay, then the staging, which is the FIGO staging. This is stage 1, stage 2 and stage 3 and stage 4. Then we have discussed the treatment options for stage 1 and separately for stage 2 and 3 and 4. And then we have discussed the follow-up for the malignant diseases of the uterus. So in the next video we will discuss the these procedures. This is the dilatation and curettage and hysterectomy and laparoscopy, and then we will end the gynae portion subject revision. Thanks for watching.